Now that you have an understanding of the body parts involved in STI transmission, we are going to take a closer look at chlamydia and gonorrhea. In this lesson, we will focus on chlamydia and gonorrhea, exploring the testing options available, signs and symptoms of the infection, adverse outcomes of untreated infections, and treatment options available. We will also discuss the case definitions that are used to count cases, and you'll become familiar with the surveillance codes that are used to reference these infections in our surveillance database. Before we get into chlamydia and gonorrhea, let's take a moment to discuss the importance of using person-first language. Person-first language means that we center the person before a particular health condition. So rather than referring to someone as HIV positive or a drug user, we'll say they are a person living with HIV, or we'll say they are a person who uses substances, because first and foremost, they are a person. All of the numbers we show represent whole humans with complex lives who are much greater than their infections and the activities they engage in. The term case is impersonal, but heavily tied to epi-terminology, so we will try to use it sparingly in this course. When used in this training, case specifically refers to someone who meets the case definition, and whose infection it will be counted when we analyze our surveillance data. Now let's talk about the testing options that are available for chlamydia and gonorrhea. Nucleic acid amplification tests, or NATs, are the recommended test method for chlamydia and gonorrhea. One of the advantages to running a NAT is that it can check for two infections, chlamydia and gonorrhea, in one test. Due to the similar routes of transmission, we see a lot of chlamydia and gonorrhea co-infections. Unfortunately, we use different antibiotics to treat these infections, so being able to test for both pathogens by running one test is advantageous. In persons with a cervix, a self or clinician-collected vaginal swab is the recommended sample type for a NAT. Many clients prefer to collect their own swabs, and data shows that self-collected swabs are just as effective as clinician-collected swabs. If a clinician is performing a pelvic exam, an endocervical swab may be performed. A first catch urine specimen is acceptable for a NAT, but urine samples from persons with a cervix are a little less sensitive and may detect up to 10% fewer infections when compared with vaginal and endocervical swab samples. In persons with a penis, a first catch urine is the recommended sample type. However, a urethral swab is just as effective. NATs have been demonstrated to have improved sensitivity and specificity when compared to culture for detecting chlamydia and gonorrhea at rectal and oropharyngeal sites, and certain NAT platforms have been cleared by FDA for those extragenital sites. Cultures are less commonly used. A culture is when a laboratorician will attempt to grow bacteria from a specimen that is collected. Cultures can be particularly useful if you're trying to determine if someone has a strain of gonorrhea that has become resistant to medication. The Maricopa County Health Department is one of several sentinel sites throughout the nation that collect gonorrhea specimens and prepares them for antibiotic susceptibility testing so that we can continue to monitor resistant patterns in gonorrhea. In 2020 and 2021, we observed some shifting towards the use of cultures due to a shortage of NAT testing equipment. You may also see an occasional gram stain for gonorrhea. Gram stains are less sensitive and would not meet the case definition for a confirmed case of gonorrhea, but they would be sufficient to meet the case definition for probable. We'll explore case definitions in more depth later. Now let's take a look at chlamydia. Chlamydial infections are caused by bacterium Chlamydia trachomatis or C. trachomatis. Most females and half of males infected with chlamydia will be completely asymptomatic. Those who have symptoms may experience abnormal discharge, burning during urination, or if the site of infection is the rectum, rectal pain and/or bleeding. If left untreated, chlamydia can lead to infertility. In women, chlamydia can cause pelvic inflammatory disease, which is an inflammation of the female reproductive organs. Chlamydia infections can also lead to ectopic pregnancies, which were described in the anatomy slides. Due to the asymptomatic nature of these infections and severe outcomes in females, persons with a cervix are key populations for screenings. If a pregnant person is infected with chlamydia, they can pass that infection onto their baby, resulting in premature delivery, low birth weight, eye infection, and/or pneumonia. We use the CDC case definitions to determine which case reports should be counted for surveillance. The CDC case definition for chlamydia was last updated in 2010. A case will be confirmed if you receive a reactive lab result for C. trachomatis by culture or NAT. At the time of this recording, our electronic labs for chlamydia are set to auto-close upon attachment, using the information from the lab report. We may reopen a chlamydia lab to add treatment information and update the disposition to reflect that the person received treatment, but we do not routinely investigate these cases. As mentioned in the previous slide, we use the disease code 200 to indicate a chlamydia case. If an infant meets the chlamydia case definition, we would use the disease code 220. The good news is chlamydia is one of many curable STIs. There was a slight shift in the 2021 treatment recommendations. Previously, azithromycin was the recommended treatment and doxycycline was the alternative. In the 2021 guidance, the recommended treatment is doxycycline, 100 milligrams, orally, 2 times per day for 7 days. Azithromycin is still an acceptable alternative, and there may be some cases who benefit from the use of azithromycin. Persons who do not tolerate doxycycline well or do not have a safe place to store their medications may be a better candidate for receiving azithromycin. We could consider someone appropriately treated if they receive any of the recommended or alternative treatments described in the 2021 treatment guidelines. Before we move on to gonorrhea, we have one more topic to cover in chlamydia: lymphogranuloma venereum, or LGV. LGV is a more severe form of chlamydia caused by 3 specific variations, or serovars. It's uncommon, but we do occasionally receive a case report for a suspect case of LGV. LGV is curable, but it requires a longer duration of treatment relative to non-LGV chlamydial infections. With a typical chlamydia infection, you only need a week of doxycycline, but for LGV, you need to take doxycycline for 3 weeks. Similarly, the alternative regimen, azithromycin, is typically prescribed in 1 dose for regular chlamydia infections, but you need to take 1 dose a week for 3 weeks to clear an LGV infection. LGV can be asymptomatic. In symptomatic cases, LGV can cause severe inflammation and invasive infection. LGV can present with discharge, anal pain, constipation, genital ulcer disease, swollen lymph nodes, and/or proctocolitis. Proctocolitis is common with rectal exposure and can mimic inflammatory bowel disease. A definitive diagnosis can only be made with LGV-specific molecular testing. Often in practice, if LGV is suspected, a provider will treat as if, rather than ordering the test required for a definitive diagnosis. None of our STD county labs offer LGV serotyping, though this test can be ordered through private labs for a cost. LGV is reportable under chlamydia as of 2022. Suspect LGV can be reported under the classifications verified or likely. If LGV-specific testing is performed and LGV is detected, it will meet the case definition for verified. If a person meets the confirmed definition for chlamydia and they demonstrate clinical signs and symptoms as described in the previous slide, and they do not test negative for LGV-specific testing, then they would meet the definition for a likely LGV classification. Now let's talk about gonorrhea. Gonorrhea is caused by bacterium Neisseria gonorrhea. The name gonorrhea is Greek in origin. Gono comes from the Greek word gon, meaning seed or generation. This is also why the ovaries and testes are called gonads. Rhea comes from the Greek word rhoia, which means flow. So gonorrhea basically means seed flow. You may recognize that rhea also appears in the word diarrhea. Now you know why. As with chlamydia, the majority of females infected with gonorrhea will not have symptoms. Males are more likely to be symptomatic, but 10 to 20% will be asymptomatic. Keep this in mind when we look at the screening recommendations for gonorrhea. For persons who are symptomatic, abnormal discharge is one of the classic symptoms of gonorrhea. Other symptoms can include burning during urination, painful/swollen testicles, though this is less common. Persons with vaginal exposure may experience bleeding or spotting between periods, and persons with anal exposure may experience rectal discharge, anal itching, soreness, bleeding, and painful bowel movements. If gonorrhea is left untreated, it can lead to infertility, pelvic inflammatory disease, and ectopic pregnancies, which are the same adverse outcomes we see with untreated chlamydial infections. Gonorrhea can also lead to long-term pelvic or abdominal pain. As with chlamydia, if gonorrhea is passed to a baby during pregnancy, it can result in miscarriage, premature delivery, low birth weight, and/or eye infections. For surveillance, we use the CDC's 2023 gonorrhea case classification. Any person with a reactive culture or NAT for N-gonorrhea will be a confirmed case. As mentioned in the testing section, persons with a reactive Gram stain would meet the probable case definition. 300s represent gonorrhea infections in our surveillance database. A 320 disease code would indicate an infant infected with gonorrhea, and a 350 disease code would indicate a resistant gonorrhea infection. While we do test some specimens for antimicrobial resistance, most 350s are entered in error. So, if you see a 350 code, you will want to double check that the lab supports the use of that disease code. Gonorrhea is also a curable infection. However, as we've discussed, gonorrhea is one of many pathogens that is slowly growing resistant to the medications that we use to treat it. Maricopa County Roosevelt Clinic has been one of several sentinel sites throughout the nation that submits gonorrhea specimens to our CDC regional lab for resistance testing, so that we can monitor the ongoing threat of antimicrobial resistance. Due to this work, at the end of 2020, CDC released an MMWR report changing the recommended treatment for gonorrhea. You may still see providers offering dual treatment with 250 milligrams ceftriaxone and a gram of azithromycin. Please note that the current treatment recommendation for gonorrhea is 500 milligrams of ceftriaxone only. The resistance profile for azithromycin has increased, so we are no longer recommending azithromycin in combination with ceftriaxone. Also note that the dose has increased to 500 milligrams for persons weighing less than 150 kilograms, which is approximately 331 pounds. For persons who weigh more than 150 kilograms, they'll actually need a full gram of ceftriaxone. Although azithromycin is no longer recommended in conjunction with ceftriaxone, we would consider someone dually treated with azithromycin and ceftriaxone to be appropriately treated for surveillance if they have received at least the recommended 500 milligram dose of ceftriaxone. Ceftriaxone is administered as an injection, usually in the arm. It is possible for a provider to prescribe treatment for partners without doing a physical exam on that partner. This practice is called expedited partner therapy, or EPT. Since the provider is not evaluating the partner under EPT, typically they would use cefexime for partner treatment, since cefexime is available in a pill form and does not have to be injected. It is important to note that although there are alternative treatment options for genital and rectal gonorrhea infections, pharyngeal infections are a bit harder to clear, so ceftriaxone is the only treatment option if a client tests positive at the throat. It is also recommended that providers run a test of cure following treatment for pharyngeal gonorrhea infections to ensure the patient has cleared the infection. The final topic we will cover related to gonorrhea is disseminated gonococcal infections, or DGI. DGI occurs when the sexually transmitted pathogen Neisseria gonorrhea invades the bloodstream and spreads to distant sites in the body. leading to clinical findings such as septic arthritis, polyarthralgia, tenosynovitis, petechial pustular skin lesions, bacteremia, or, on rare occasions, endocarditis or meningitis. DGI is rare and only occurs in about 0.5 to 3% of cases. DGI can be treated, but the treatment requires a higher dose of ceftriaxone or treatment through an IV. If you see a case report indicating a non-traditional, such as non-genital, non-oral, non-rectal, site of infection, you could be seeing a case of suspect DGI. Keep in mind, we do see data entry errors, so it is important to verify the site of infection if you notice an unusual site. The last topic we will cover in this lesson is how to deduplicate cases if you receive multiple reactive test results for a chlamydia or gonorrhea infection. Although these infections can be treated and cured, it is possible for persons to test positive for a period of time following their treatment and for persons to become reinfected after treatment. We deduplicate cases of chlamydia and gonorrhea using the 30-day rule, which means if someone is still testing positive within 30 days of their original test, we do not consider them reinfected and we only count them as one case. If, however, someone tests positive more than 30 days after their infection for surveillance, they are considered reinfected and counted as two cases, even if they never received treatment for their original infection. If someone receives treatment within 30 days of their infection, they are still only counted as a reinfection if they are still testing positive more than 30 days after treatment initiation. Let's look at a couple of examples. Take a look at person A. They tested positive on January 1st, and by January 15th, they are still reactive. We would count this as one case because they are still within 30 days of their original infection. With person B, they are still testing reactive on February 5th. Per our surveillance guidance for deduplication, we would have to consider them reinfected in February and count them as two cases, even though we have no documentation of treatment. What happens if a case is treated? As we discussed, if a person is treated within 30 days of their infection, we use the day of treatment as their new frame of reference, rather than the day of initial infection. Take a look at persons C and D. Both C and D were initially positive on January 1st, but they received treatment on January 15th, which is within 30 days of their original infection. Because they received treatment within 30 days, instead of using the initial test as a frame of reference, we would use the day of treatment as a new frame of reference for reinfection. This means they would still only be considered a reinfection if they are still testing positive after February 14th. Take a look at person C. Like person B, they are still testing positive on February 5th. But unlike person B, they received treatment on January 15th. So we would only count person C as one case, and we would not consider them reinfected since they are testing positive within 30 days of their treatment, and they received treatment within 30 days of their infection. Now let's take a look at case D. They were also treated on January 15th, but they are still testing positive on February 30th. They would be considered reinfected, and we would count them as two cases because they are still testing positive more than 30 days after their treatment. Let's take another look at person B, except this time let's say they were treated on February 5th, more than 30 days after their infection, and they are still testing positive on that day of treatment. Since the treatment was initiated more than 30 days after the infection, we cannot use the day of treatment as a new frame of reference. Since they are testing positive more than 30 days after initial infection, we would have to count them as two cases, even though they didn't receive treatment until February 5th. In this lesson, we have discussed that gnats are the recommended test for chlamydia and gonorrhea, but you may also encounter some cultures and gram stains in your work. We've also discussed that most women infected with chlamydia and gonorrhea will be asymptomatic. We also see about half of men infected with chlamydia and 10 to 20% of men infected with gonorrhea being asymptomatic. For those who are symptomatic, they may experience things like discharge, painful urination, and rectal pain or bleeding, for those with rectal exposure. Adverse outcomes can include infertility, PID, and ectopic pregnancies. Both chlamydia and gonorrhea can cause premature delivery, low birth weight, and eye infections in exposed newborns. Both chlamydia and gonorrhea can be treated, although gonorrhea is on the watch list because it has gained resistance to most antibiotics, with the exception of ceftriaxone. Most cases of chlamydia and gonorrhea will meet the confirmed classification of the case definition if they are reactive on a gnat or a culture. If you see a gram stain for gonorrhea, then it would be classified as a probable case, unless there is also a reactive gnat or culture. We also covered the concept of deduplication, and that any case of chlamydia or gonorrhea that is still testing positive after 30 days of original infection or after 30 days of treatment, if treatment is administered within 30 days of the original infection, would count as reinfections in our database. Finally, you should now recognize that the disease code of 200 indicates chlamydia and a disease code of 300 indicates gonorrhea.